At the first topic will be the mucormycosis. In 2012, Professor Guan Chung already proposed the new taxonomy of the mucormycosis. This is the old one, the classical one. Yes, kingdom fungi divided like this, but after that, she proposed the new taxonomy that make most of the physicians get confused, right, about the name. But it doesn't matter. Yeah, whatever we can understand each other, that is the best. Okay? And this kingdom changed like this to make it simplify. Okay? The Ascomycota or the septate hyphae belong to the Ascomycota and Basidiomycota, whereas the Zygomycota, or we know known as the non-septate hyphae, still, okay, we still know that it's non-septate hyphae. Dr. Chen just no. Okay, it doesn't matter, okay? Yeah, we just have two orders that belong to the order Mucormycotina and subphylum Entomopteromycotina. Okay. These both, most of them are the pathogenic fungi, which has the non-septate hyphae. Okay. So before we go that, we should understand both of them. And what is the same of both of them is that both of them are the pathogenic form, are the same, non-septate and a similar size. So how can we differentiate from that? Fortunately, yeah, many things, yeah, like a pathogenic form, the host, the underlying disease is quite different. But whatever typical is untypical. So let's see this case. This case we got in our hospital. It's the laborer, 51 years old, and he's a driver to transfer the soil from one place to another place. And he got the abrasion in the forehead. And his eyes almost cannot open. So we got the sample and stained like this. We saw the non-septate hyphae here with the multinucleated giant cell. You see, histopathologist is very important. So we should focus with that group, yeah, to create our microbiology, okay? Yes. And after that, we also got the culture. From the culture, just like Lysopus, it's a cotton light. But for the patient, how do you think? You think it's order Mucorales, or you think it should be not? From the lesion, the physician think that it will be Entomopterales. But from the culture, it's just similar to the Lysopus group. At last, after we do the PCR, it is Saxinia vesiformis. Yeah. Fortunately, from the culture, yeah, and we have the communication. Another thing is communication, don't forget. The communication with every group, yeah, it can help, can save the life of the patient. And this one, they use amphotericin B after got the culture, okay? And 40 days after the treatment with amphotericin B and itraconazole, the patient really better. Yeah. The sporation is also different. In the order Mucorales, is more spores in the sporangium, whereas the Entomopterales is only one spore on the one conidiophore. How about the publication for the mucormycosis? It's really increasing after 20th century, almost 200 or more than 200% increasing. So how about in our area? Because our area is really tropical and subtropical. The fungus really love that. Not only that, also the hot, the warming, right? And the dust. It's really, fungus really love the dust and also the warm temperature. Here, I would like to show you the underlying disease of the mucormycosis. You see, the pattern is quite different. Yeah, we divide it into the DM and non-DM, which is all the malignancy. And here is a period of the presentation and the location of that. For the developed country, yeah, most of them are the HM malignancy, whereas in India, also I think in Thailand too, and in Mexico, I'm not sure for the Indonesia or for the Malaysia, yeah, most of them is shown that it's a DM more than HM. So we should focus on these two for the underlying disease. And may I just present you on the Mexico study. They hit the database using the keyword of the Mucormycosis, Entomopteromycosis, the Mexico, English, and Latin language. And they found the report into 3 periods. And all the periods, the DM is increasing and increasing. Not only that, also the malignancy also increasing. Yes. So how about over there? The type of infection also difference in these 3 groups. This is the diabetes group, and this is malignancy group, and the other more than 2 of these groups. You can see most of the diabetes will be the sinusitis, whereas the malignancy is more aggressive. Then in the lab part, we should support them. Yeah. Here for the specialized center, they can diagnose the very good result with 100%. And for the culture, also very good, yeah, more than 90%. Whereas the non-specialized center here, we can do it, right? If Mexico can do it, why not Asia cannot do it? We can do it, direct examination, very fast. Only 1 hour, yeah, you can get all the result. And this is not fun, so they can help the patient at least. And here about the list of the culture, the causative agent. Most of them are the Rhizopus. So yesterday from the Dr. Farooq's place, you know what is the Rhizopus. And here is the pattern of the list of the causative agent. Most of them are the same in Europe or in Asia, in India. As a representative, Rhizopus come the first. And then in India is a Pythiosis, whereas the erythemia is in Europe. How about India? Then may I share you the sinusitis and orbit infection in the tertiary care eye and ear hospital in Massachusetts in USA during 20 years. Yeah. They found 24 confirmed cases by the histopathology. Again, histopathology. So pathology is another target for us to initiate them. Mucormycosis is 14 here in orbital infection, whereas aspergillosis is only 7. And how about it's only 1 in the 7 cases. Mortality rate really increasing, 9 from the 11. However, we have to really aware that this is a tertiary care eye and ear specialized. And how about the aggressive? Here at the time after diagnosis until they pass away, only 25 days, whereas aspergillus is more than that. So really aggressive because Rhizopus is very fast growing. And the man is more risk than the female. Here, the mean age almost the same. This is another report to indicate that the mucormycosis is IFD, an increasing rate. It's higher mortality rate than aspergillosis, as Dr. Chen and Dr. Tan talked yesterday. And here is the resistance to voriconazole. But however, we have something to help. Before we go into the treatment, yes, here is from Dr. Tan's slide yesterday. They suggest that by the MD Anderson Center, right? They show that the reverse halo signs can present in 19%. Yeah, this is just some suggestive. We cannot take it as a typical here. Then how about overlap? Yeah, since I'm in the lab part. Yes. Correct the specimen. Are we ready for that? How about the transportation? Not on ice, please. Yeah, we are in a tropical country. We don't like the cold weather. So just warm weather in the room temperature is enough. Not like in this room, okay? Yeah. And then for the processing, we have to put in the sterile container. Just put only a small amount of the water or the normal saline. That is enough. And then in the lab part, cut into the small pieces. Don't forget, the fungus always inside some tissue, except that's colonization. Yeah. So after that, we have to cut it and then look at the direct examination and report to the physician. So they do know how to manage the patient. Or if you just say that we don't have the KLH preparation, it doesn't matter. We have the gram stain AFB. Like yesterday, someone talking, the misdiagnosis. AFB or Grand State, we can see something like a ghost tape or ghost pipe in the slide. That is also help us. Histopathology again. H&E, PAS, see the tissue reaction, whether they have granuloma or not. The shape using the GMS, this is really helpful. The culture, very fast, 2 or 3 days at 30 or 35 degrees Celsius. If you say that you don't have enough incubator, just hold on the bench. Don't forget. Please be aware of the mite. Fungus really love mite and mite really love fungus. Identification. You want to do the classical way or you want to do the PCR multi-top. In here, if you cannot do it, you just send to Dr. Fairuz. Dr. Fairuz is here. I think she loves to do it, right? And for the serology, negative, GM, characteroman, and also beta-glucan. So how can we do it? We still have something. This is MD medicine. Here is the pathogenesis of the mucormycosis. This is normal into the sinus or like in the lung with the size of the spore. They have 2. So this is a kind of differentiate which kind of a fungus that can go into the fungus in amina or the Mucormycosis. The small one can get into the alveolar, and the big one can get into the sinus, or sometimes it just invade up to the cranial. For the healthy host here, the macrophage, the neutrophil will be very healthy, and they can kill the germ and do not invade into the blood vessel. But whereas for the suppressive patient, they take the steroid, or for the malignancy group, or the neutrophil, the macrophage will be weakened, and then they impair the migration of the macrophage, the ingestion of phagosylysosome fusion, and impair the chemotaxis, and they decrease the fungicidal mechanism. This is another thing that make the germ or the Mucormycosis member get into the blood and make the NGO invasion. Don't forget, our area is DKA is a lot. So this is higher glucose level and free iron. This is something that really promote the invasion here. I'm really happy to see this one. Dr. Chakrabarti told me you have to talk in this one. I said, oh my goodness, what is this? Here, really new for me. Here, the mucormycosis, they have a very specific, because we always say that, how can we differentiate mucormycosis? We have a hope. Here, spore coat homolog protein on the pathogenic site. And for the host site, they have the glucose receptor protein. And 2 of these are just matching. They can just hit each other, bind to each other. And they have several experiments like this. The spore coat protein homolog can present on the lysopus that is a normal pathogen in this disease. And then they can mediate a specific interaction with the here, Y shape, and this is specific on the pathogen. And then promoting the fungus adherence and invasion. Then they have the member of COT 1, 2, and 3. And the 3 is the most important one. And they also study that the heterologous expression of the lysopus COT-H protein resulted in the membrane cell invasion by using the normal yeast, Saccharomyces cerevisiae. And also, they found that the interruption of the COT-H function in lysopus disrupt or decrease the invasion of the potential. So this is something that I just give you. And if you're interested, you can read this one. They have a group of the presentation, very nice one. And so from here, they propose that this is a promising therapeutic target. Not only that, also can use as a diagnostic tool too. How about the treatment? May I jump out because yesterday Dr. Patel has already talked about the isoproconazole here also. How about this case? This case have a thalassemia, underlying disease, and with a rapid progression lesion for 3 months. Here, it's very pity. he has a history. Don't forget the history is very important. Yeah. Planting a swampy area before the lesion occurred. And KOH paper, direct examination again, non-septate hyphae. What? How do you think? What do you think? Non-septate hyphae, antifungal agent, posaconazole? Right, Dr. Tan? No, we don't know. Yeah, we have to see the endemic zone. Yeah, how about our endemic zone? CTA also see the occluded because we have the thalassemia and something like this. So we just suspect of the Pythium insidiosusum. We do the ELISA and positive. So the diagnosis is Pythiosis. Here, the treatment, debridement, because we don't have the standard treatment at all until now. So we use a three as follow the previous publication. Debridement or surgery, oral antifungal agent combined with the immunotherapy. That's from the protein here. And become better after 24 days. So what is the causative agent? Pythium, mostly is 99% is Pythium insidiosum. And it really go very fast on any kind of medium or in the blood. Here, everything just look like, right? Fungus. That's why we call fungus-like organism. Even that is far away from fungus. It's just close to the algae. And with the help of these 4 groups, 4 genes, they can divide it into 3 crates. And these 3 crates distribute in the different location. In our area is crate C and B. And how about the natural habitat? The natural habitat is normally in the agricultural area or in the dam and around the root of the plant and in the hyphae form. We, especially the underlying disease, just get into their natural source, right? And with a trauma, so the zoospore will attach to the lesion and then invade and then cause the disease. How can you do? Because this is gangrene. How can we differentiate from other anaerobic infection? This is acute. This is the first case in Thailand. I think it's the first case in the world too, in 1987. The number of the cases in 80 years, you can see like this, 102. But afterward, the increasing cases is increasing like this, 5 and 5 years, almost the same. Here, you see, both vascular and eyes form. How about the propagation? After 2006, the case is almost 2 times from before. This is something that I'm quite happy because most of the physicians and also the lab know what is the Pythium insidiosum. And not only in Thailand, which is the most highest incidence of the Pythiosis. In Asia, the case has become more. In Malay, right, 2001, and in India, more keratitis. Most of them are the keratitis case, not the vascular case. I'm really sure that we have it in Malay, in Indo, in around our area, but why not? So shall we just seeing the clinical part. Here they have the vascular on this side, and then the leukocytes in the oral, in the orbital, and in the keratitis. Then, how about the symptom? I just point out the different one. The symptom for the vascular type is really obstruct the arterial. And the underlying disease in Thailand is with the red blood cell abnormal. Mostly are that. History, agricultural related occupation, the farmer or anyone who have the history of the water exposure, so as the eye, water spill into the eye and get the corneal infection. For the diagnosis, for the vascular type, you can occlusion by the angiogram, but angiogram is very expensive. So how can we do that? We can use anyone who have the suspected case, just do the ELISA. Also, they have the other serological test. Isolation, we can use for both, for vascular and eyes. Molecular approach for identification, or directly from the specimen. Histopathology again. The treatment, no standard at now. So they use the amputation, debridement until the absolute margin. Antifungal agent and immunotherapy with PIA, the protein. May I share you with the two publications? This is the treatment outcomes in our hospital during 10 years. We just have 18. Just take this one. And 9 of each type, we found that the case can survive is around 56%. And definitely, the definitive surgery with adequate surgical margin is very important, but unfortunately, the patients always come late. So that's why the percentage is quite low. The ocular type, 55%, is underwent inoculation. Have really pity, and the age is something relative to the inoculation. The higher non-inoculation cases in our center is higher than in other center. Might be about the concern of the physicians. And this is in another center for the vascular pythiosis in the northern part of Thailand. It's 10 years experience. Also have the same thing. Successful management requires early recognition. So the lab part, are you ready for this one? For classic clinical presentation here, this is very important. Just take a look and try to put in the chip. Underlying thalassemia or red blood cell abnormal. History of previous limb wound. Know here the risk and presentation with acute or chronic limb ischemic. Important is that whenever you have suspected cases, test the serum very fast and not invasive, right? Survival rate is about 64%. This also used PIA combination. The only effective treatment was complete excision of the infected, which was done mainly by the major amputation. And I just would like to share you, this is already published here. Because someone, I heard that you have the limitation of using the PCR. You can use here, thermophilic helicase DNA amplification, or we call THDA in short. This one, by using the COX-2 specific primer with a constant temperature at 65 degrees Celsius. It is very rapid, accurate, and species-specific identification. It can amplify, you can see the picture, yes, the Pythium insidiosusum and all the Mucormycosis, and also the related, the friend of the Pythium. So how can we separate or differentiate the Pythium? By using the enzyme CVIK1, so we can differentiate. This is only in 1 day, very fast. So we do know how to take care of the patient. The limit of the detection with the one step is about 100 picogram. But if you add the preparation by denature 5 minutes before you start the reaction, it really 100 femtogram. It's a little better. And may I just give you some home message that I already talked. The mucormycosis, underlying disease is changed from, not it's changed, but it's something different profile. The DM in developed country, yes, sorry to use this word, and developing country more for of the hematological malignancy. It seems like that a clear sky of the treatment in future might be isobuconazole, but it's not coming to the Asia yet. Right? And then from the translational research of the pathogenesis, they got H member, but we don't know when we can have that actually. Guideline for the pythiosis in diagnosis for the experience in Thailand. The vascular type, thalassemia agricultural, present with acute or chronic ischemia with a rapid progression and no response to the antifungal agents. How about ocular? History of water spill to the eye And the lesion just like a spider net on the cornea. The presence of the alternative, yes, and no response to the antifungal at all. Thank you very much.